Hello, everyone, and welcome to the 19th Annual Social Enterprise Conference, the Capital for Good Digital Event Series. I'm Amelia Earnest, a first-year student at Columbia Business School, and I'm so glad to have all of you here with us today. Before we start, I wanted to quickly note that this session is a part of the Phillips Pathway for Inclusive Leadership program at Columbia. That program focuses particularly on leadership and managing diversity, equity, and inclusion across industries. And if you are here as a Columbia MBA student today, you can virtually check in using the link that will be shared in the chat box below. So today we're excited to have a really engaging conversation with a great panel discussing lessons to come out of the COVID-19 pandemic. Over the past year, we've all seen the pandemic prompt a new wave of change and innovation that's touched financing, policy, and really every other industry. While we're far from understanding the long-term impacts of these changes, we're excited to dive into some of the lessons in the making today with our panel here. We're very lucky to have a wide range of voices with us representing perspectives across health, development, and policy. I'm very pleased to introduce Shanthakumar Bannirchelvam, the Managing Director of Global Impact Partners, and a current EMBA student here with us at Columbia. Rajesh Dash, an associate professor of medicine focusing on cardiology at Stanford University, and Varun Jhaveri, an officer on special duty with the National Health Authority in India. To start things off, I know I gave a quick intro, but I'd love to start by handing the mic back over to each of you to maybe give a more detailed introduction of yourselves, and also maybe to touch on how your work has specifically touched or intersected with COVID-19 over this past challenging year.
Professor Dash, do you want to go first?
Of course, yeah. No, thank you, Amelia. It's great to be here, and thank you so much for inviting me to join you. So my background, I'm faculty at Stanford Medical School. Been here about 12 years, and I focus on preventing heart disease in South Asians. South Asians have the highest rates of heart disease in the world. What I've been trying to do and focused on is do that globally as well. And with the pandemic, it presented a new challenge on top of all of that, which is that patients who have high risk or have a history of heart disease have the highest rates of mortality if they were to get COVID-19 infections. And so it becomes now paramount to really get preventive programs out there to better control risk factors. And so, in the background over the last several years, I've developed a software platform to do that at scale and across populations. And there's a huge need for innovative financing to really drive the adoption and scaling of this in the neediest sort of populations globally, not just the South Asian population, but everywhere. And so really have been fortunate to work with Sean and Varun on some of these solutions that we can hopefully bring to India and other communities around the world. We'll talk more about that.
Hi. My name is Varun Jhaveri. I'm currently working and based in India. And thanks Amelia for that very brief introduction. As Amelia mentioned, I work at the National Health Authority. In the National Health Authority, we manage one of the world's largest healthcare program called Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which essentially covers more than 500 million Indian citizens against catastrophic healthcare expenditure. So, by the sheer scale of the number of citizens that we cover, of course, we had quite an active engagement during the COVID pandemic. One of the big challenge was how to continue the provision of, non-essential COVID healthcare services, for the beneficiaries that we are covering. And, these are the beneficiaries who are at the bottom of the poverty. So, around 40% of India's population. So, would be happy to share some of the interesting things that the country did. And as Professor Dash said about, what are some of the interesting and innovative financing mechanisms which can be leveraged. So, I think going forward, I think that is going to be one common theme that I think all of us are going to talk a bit more about. So yeah, very happy to be here and, looking forward to the discussion.
Thank you, Varun. It's a pleasure to be on the panel, Amelia. So my name's Shan. I'm currently an EMBA student and also managing partner in Global Impact Partners. We're an institutional impact investment advisory firm based in Singapore, as well as with offices in Delhi, in India, and Northern Australia, focused on mobilizing capital to serve people on the planet. A big focus within this has been healthcare outcomes-based financing. And this is where we've been working both with Professor Dash, as well as governments, both in India, as well as in other countries around the world, on really seeing how we can finance healthcare solutions through a model where we basically finance the upfront cost of preventative programs and then look to share in the savings that delivers as a way of really scaling value-based care within these systems, but very importantly, strengthening and building back better out of our response to COVID-19. So really glad to be here and share some of these insights with you in the audience today.
Great. Well, it sounds like there's a couple of themes that really touch on obviously all of your work, particularly since you guys have worked with one another. But maybe one place that I think is interesting to start is sort of around this point of the collateral damage around other health areas that have come out of COVID-19 and the need to really hyper focus on stopping this pandemic. I know, Varun, you mentioned, you alluded to this a little bit, the effort to continue to provide those services for other health priorities. Maybe we could start there and have each of you comment on what innovations or efforts or even failures that we've seen in terms of trying to meet other health needs despite a global lockdown and an overarching sense of priority that we really need to stop this pandemic.
Sure. Thank you for that, Amelia. I think, right from the, inception of the pandemic, one thing that became, quite prevalent was that, the Indian government, it announced a lockdown. And, if you look at the entire global scenario, most of the countries, imposed some sort of a lockdown. Again, depending on, there was difference in terms of the severity and the strictness of the lockdown, but more and less, as you said, that there was a global lockdown. I think once the lockdown was in place, there was, I would say, a lot of confusion across the globe with regard to who will provide the COVID services, which hospitals will provide the COVID services, and which hospitals would provide the regular non-COVID related services. And I think that is where the Indian government tried, and we met, I would say, a fair amount of success, wherein the idea was that you do a lot of centralized policy making, but you do a lot of decentralized implementation. So the idea is that you guide a lot of your states, you guide a lot of your provinces, but when it comes to the implementation, you let them take a call, because every geography is very different, and it depends a lot on the spread of the disease in that particular district. So right from the start, we were fairly engaged in, first of all, identifying that these are the hospitals which would be dedicated COVID hospitals. So it can either be an entire unit which is getting earmarked as a COVID hospital, or it can be a dedicated wing in a particular hospital. But the idea was that you separate this and you pass on the information to the citizens, so that the idea is that when you look at diseases such as NCDs or emergency care casualties, they are a lot of times they are more fatal than the COVID itself. It is really difficult for that particular citizen to actually wait to take that treatment. So I think this bifurcation really helped. At the same time, what we did is that as of now, we have around, more than 24,000 hospitals which are there in our network. So what we did is that we started empaneling more hospitals which can actually provide non-COVID related essential services, especially for hospitalization. If there's an urgent need for someone to undergo a bypass surgery, if someone needs to undergo, surgeries which do not really offer a lot of time. So for them, we started empaneling more hospitals. We rolled out a technology module which was very simple for the hospitals to register their interest and become a part of our network. The second thing that we did was that we started sensitizing the citizens about the inception of the pandemic, and about the difference between the COVID related healthcare services and the non-COVID related healthcare services. And we started informing that where do they need to go for the COVID versus non-COVID. So that information awareness, and that information awareness happened, from the very top level to the, to the health worker level, so that everyone is informed and, can cater this information to every single citizen. Third was that we took a lot of help from a lot of technology. So, whether it was with regard to introducing new applications, or whether it was with regard to, partnering with the existing providers, who have that type of technology efficacy. So, we actually took a lot of help from them. Fourth one, which was a very critical one, was with the partnership with the private sector. I think a lot of private sector hospitals, they came forward for either volunteering for the COVID-related healthcare services or for the non-COVID healthcare services. So the government actively partner with the private healthcare sector in provisioning this particular healthcare services. But in and all, I still feel that, of course, because of the lack of mobility, the non-COVID healthcare services, of course, has experienced some sort of a dip. But I think now, things have happened much better. And I think this also gives us a lesson about how to be much more prepared in terms of, when there's such a pandemic-related emergency. But yeah, this is, some of the 3-4 things that, the government actively took up and, met with fair amount of success, I would say.
That's wonderful to hear. And I guess one question I have in follow-up to that, although I don't want to cut off our other two panelists from commenting on that question if you guys want to jump in, but I guess in one point in follow-up to that I would be curious to hear is how how you see those outcomes and those lessons or relationships being sustained and brought forward in the future. For example, I know that there have been other types of epidemics where maybe these kinds of partnerships were formed and maybe they need to be reformed in this instance. Do you feel like that's the case, or do you think this is sort of unprecedented in terms of the urgency and the scale? And do you feel like this could be sort of a game-changing moment in terms of the government's ongoing relationships or some of these other innovations in terms of sensitizing the population and other tactics that you mentioned?
Well, I have always been of the belief that, this particular pandemic, like every particular pandemic has been, more or less more of an inflection point in structuring the healthcare system. I think, if I look at this particular pandemic, I feel that this has been an inflection point with regard to, how well integrated and holistic are your healthcare systems. If I have to tie down with the concept of the capital, with the concept of the healthcare expenditure, what we have really realized is that it is not only the quantum of the capital which is, denoted or dedicated to the healthcare expenditure, but rather it is the effectiveness of how well you are using that particular sum of money. Because I think, for a very long duration, one of the key metric that we were focusing is that how much percentage of GDP are you using for your healthcare expenditure? I think what this pandemic has really done is, it has showcased that it is not only about the quantum, but what is the effectiveness that is actually, that expenditure is bringing. And I feel that there are 3, strong points that I believe is very important to tie with the effectiveness of the capital that you are putting in the healthcare. One is whether that capital is enabling a holistic health system. Whether your primary systems are talking to secondary, tertiary, whether your public systems are talking to private, and whether it is leading to information symmetry. Because one of the biggest focus was with regard to information symmetry within COVID. If there were systems which had information symmetry between the healthcare providers, policymakers, citizens, healthcare workers, those countries have done relatively well. The second one is that whether the type of spending that you're doing is increasing the quality of care and the clinical health outcomes in the longer runs. I think that has been, extremely critical. If you look at, some of the Southeast Asian countries, you will see that because they had some of the historical experience of facing the SARS, the MERS, they have relatively done well in the pandemic because, the type of the spending that they had done, that was done keeping in mind the overall outcomes of the, the overall health outcomes. So I think that was the second very important thing. The third thing is that the type of spending that you are doing, is it helping in increasing the access of healthcare to every single citizen in your country? I think what this pandemic really says is that if there are a large number of citizens who do not have the access to the healthcare, then the healthcare system is going to get extremely burdened, especially during the pandemic, and that is when you are actually going to reach a particular stage when the health system is going to break down. So I feel that this is definitely an inflection point. Of course, there are a lot of lessons. There are lessons for technology, there are lessons for infrastructure. But if I have to talk, because the conference is focused more on the capital, I would say that if we have to talk about the capital and the health system, I think this pandemic is a great lesson for us to start thinking about how to use the capital and what type of value and effectiveness the capital needs to get in terms of the health system financing.
Yeah, that makes a lot of sense. And I know that plays in a lot of other trends around value-based care that were already happening. Hopefully just accelerating those things alongside of the many other changes that COVID has accelerated. Hopefully things beyond just everyone's addiction to Amazon. So it's good to hear like the positive things that are moving forward. I guess to that point, Sean and Rajesh, I know you both have a lot of like overlap in terms of some of those themes on value-based care in particular. So I would love to hear maybe both of you comment on I guess maybe two things. One, how we're measuring success, both in the past, currently in the pandemic, in terms of how we're gathering data and defining success, and how we see that maybe that changing going forward, hopefully as a result of what we're learning. And then as a second part of that, maybe commenting on how that intersects with value-based care.
Sure. Perhaps Professor Dash, I'll let you go first, then I'll jump in.
Yeah, it's a great question. And I think that, prior to COVID and the pandemic striking, I think that we had a lot of silos in terms of data that was being curated and gathered by different organizations. Those could be companies, they could be government entities, and research labs that were focused on their own products for particular disease states. And I think everyone has seen what is remarkable in that the last year with the pandemic striking, the incredible effort to develop vaccines and to validate therapies. And separate or parallel rather to that has been an unprecedented level of data sharing in terms of results, experiences, observations in certain populations. There's been, that's good and bad. There's definitely a risk of sort of the quality of the data, interpreting the data, and having good scientific review of the data. But really getting back to your point of value-based care, I think that in the end, you have to look at both the efficacy of treatments as well as the cost of those treatments and the downstream impact of those treatments, right? So this is something that we've been working on, Sean and myself, for a couple of years now, trying to create that opportunity just in general across chronic disease management, whether it was diabetes, heart disease, stroke risk, these kinds of things, because single payer health systems, which are value-based and really incentivized to prevent major or bad outcomes from the healthcare standpoint for their population, they're incentivized to keep their patients or their population healthy, are really the ultimate manifestation of value-based care. And I wish we had a much more consistent model like that in the US, but we look to these international health systems as, in my view, role models for how we can potentially create value in the healthcare system. And I think that, what we've learned from the pandemic is that this type of consideration is maybe not, I wouldn't say it's been prioritized as the most important consideration. Value-based care, people have really been pouring lots of resources into developing these products and at whatever cost trying to get what the most effective treatments are to the patients. What we're now seeing is analytics around the data that's coming back as to, okay, this really expensive drug is marginally effective in reducing length of stay in the ICU. Okay, is that really going to be the true treatment for this pandemic, for this sickest patients? Or is it going to be this generic steroid that actually does a much more effective job, right? And so these kinds of analyses are going to now emerge and become really valuable for every health system in terms of getting value from those treatments and maximizing the outcomes. So go ahead, John.
I mean, one thing we've really been looking at here closely, Amelia, and it definitely is varying depending on which stage countries are at, is really looking at how we can tie in with the impending vaccine rollout, which we're starting to see emerge in some of the LMICs we work in, as well as places like Australia and the UK, where we think there's a significant opportunity in the 15 to 30-minute window post-vaccination to actually do comprehensive screening for this impending, I would say, NCD pandemic that we have been in for a while, that will continue. And when we look at something like sheer death rates, I think, about 17 million people a year die from from cardiovascular disease alone annually. And I think that death toll will only continue in the coming years. Similarly, what we saw when you start to dive into the granular data on COVID-19, right? From the data the WHO and UNDP teams had shared with us, I think it was something like 1.4%. This was, I think, about 2 or 3 months old. So the data may have changed since then, but you're looking at about 1.4% mortality rates with no pre-existing comorbidities. On the other hand, someone with cardiovascular disease had a 13.2% mortality rate. I believe hypertension was 9.8, and then diabetes was at 9.4% from memory. So there's a significant threat multiplier as well within these at the individual patient level. And very much to build on Varun's point, at a system level, these weaknesses where they do arise in continuity of care, and this is not just a function of healthcare spend over GDP, can be significant in actually the effectiveness to which we're managing for that continuity within that. And I think that's where we've seen opportunities both in India, Indonesia, and elsewhere, where leveraging the kind of community healthcare network, a lot of these systems which have been in place pre-COVID-19 as a key platform to both respond to COVID-19 as well as build back better out the other end of it. And I think that's a key theme we see, and a real opportunity to sort of, allow for innovative finance to come together with health solutions to scale our response coming out of this. And importantly, at a fiscal level, to create the fiscal space for governments through these kinds of public-private partnerships, right? Because, budgets have definitely been hit through this entire period. Certainly, while, of course, increased allocations to health have gone up, the reality is that is going to sort of hit somewhere down the stream in terms of that sort of fiscal spend at national level. So that's a key part we see, the ability to contribute to this. If I can draw an analogy, in much the same way we saw infrastructure investment, right, about 30 years ago, start to expand the fiscal space for governments to expand infrastructure like, toll roads, ports, power, etc. In the same way, we think as we build out of COVID-19, there's a real opportunity in building the social infrastructure and financing that through these types of PPPs.
I'd probably just add on to his comments about the screening program and the 15-minute observation period after a vaccine. Why do we care so much about screening for high cholesterol, diabetes, hypertension? In San Francisco, we had an earthquake in 1989 called Loma Prieta. And in the week after that earthquake, there were almost 0 heart attacks admitted to hospitals. People, it was like there was this huge event and then no heart attacks for a week. And that's very rare, right? No one can really remember a time when that happened, but it was basically that acute event created a lot of stress, and the people who were going to have their heart attacks in the next week basically had them that day. And then no one had one for a week, right? So what we're seeing with COVID is obviously more protracted than that. But what we're seeing is that in the acute period of the COVID infection, there is a huge number of cardiovascular events. And I'm going to share some slides here. We're doing work with the FDA, with the software platform, HealthPals that I've developed, and it's showing remarkable data on the rates of heart disease post-COVID. And it gives you a flavor of why we need to screen for patients for their chronic diseases, because COVID is not going away. And we're going to be dealing with this likely for years. And we might even be getting yearly shots, we don't know. But we're going to need to deal with that issue. So I'm going to share my screen. You should be seeing, this is work that we just reported to the FDA about a week ago, based off of 35 million patients in the US with both claims and EHR records. We have a partner Paradigm for that data. And we're working with these two foundations that are part of the FDA essentially and working on COVID-19 solutions. And, it's based on this concept of, we're tracking who's getting what treatments at what time, are they getting what they should be getting, and are they getting something that's going to help them have the maximal response to their treatments. And that's what the HealthPals platform does across all patients in a population. It's something we're doing in other health systems, but we applied it to the US population for COVID-19. And essentially with 35 million patients across the US, we developed cohorts. We actually compared it to an influenza population. We balanced the cohorts to make sure that they were comparable. And then we looked at the results. And what we're seeing, and this is where the COVID patients are in the US that we were able to detect, and a comparable patient influenza population from prior year, and just kind of give you a sense of that distribution. But this is the remarkable result. So if you look in the first 50 days after a COVID infection, these are the rates of heart attack, stroke, blood clots in the leg, and blood clots in the lung in patients after their diagnosis of COVID-19. In the first 50 days, the rates are dramatically higher, right? So this is not so dissimilar from what happened with that Loma Prieta earthquake. It wasn't one day, it's a little more protracted because everyone's experiencing this at slightly different levels of intensity. But what it's telling us is that, when these things happen, if we don't have good prevention measures in place for these risk factors, this is likely to happen again. And we're seeing it right now, this huge burden of cardiovascular event rates that are happening, and it will continue to happen as the pandemic sort of rises and falls in terms of infection rates. As we get into the summer, great, but into the winter, what's going to happen again, right? Are we going to see another rise? And so the question now is what we're looking at is what's the impact of treatments, preventive or active, on these actual event rates? Steroids we know seem to work. Are they working in the real world in terms of populations, not just in clinical trials? And even blood thinners, are they going to protect these patients from these events in that acute period? So this is the kind of work that we're doing, but what it underscores is that there's value here, right? There's a huge value. The cost of this blood thinner may be pretty low. There's lots of generic options out there, lots of generic steroid options out there. Can we create value if we find a patient who's high cardiovascular risk after their vaccine and they're waiting and we get, oh my gosh, you have so many uncontrolled risk factors? Could we potentially prevent a major event for that patient downstream if they were to contract a new strain of COVID-19, next year, right? So these are things that we know across the population in general will be beneficial, but even in the setting of COVID could be strikingly effective if we can create that data set and that understanding of the population's risk.
That is fascinating. And that story of the earthquake, I was hoping somehow that the reason behind the lack of earthquakes would have something to do with something a little more positive rather than everyone just immediately. But I guess that seems more intuitive. I guess my first response to some of these solutions around screening people for NCDs after they get their vaccinations and having these and paying for a cheap steroid to prevent a terrible and costly health outcome, they just seem like win-wins across the board. I guess my question for all of you really is what's preventing this from happening? Is it a lack of data? Is it that it would be really challenging to even gather the data that one would need in such a fractured health system like the United States? Or is it maybe even something more human around our ideas of how we treat health?
So maybe I'll jump in here, and I might also share my screen to briefly shed some insights in the work we're doing. So just to lay a bit more context, I hope this is showing up. Basically, the Global Health Impact Partnership was a platform we set up with Professor Dash, along with delivery partners in a number of countries. And effectively what it is, the platform together with about $100 billion of institutional asset owners to invest $1 billion over the next 5 years into a series of replicable, scalable, outcomes-based financing instruments. And effectively what we're looking to do is build a model of outcomes-based financing that's now being used, and actually the numbers have gone up since this, but more than 134 projects in 27 countries, funding a whole variety of things. It's been used for diabetes prevention in Israel, in India for upgrading maternal care facilities, in Canada for stroke prevention, amongst a broader variety of areas, including social services, as well as homelessness and other such areas. What we've then focused on is zooming in on a series of countries where you can really tie this down. But in particular, Amelia, how do we solve for that and bring these pieces together, right? What we're effectively doing is really bringing together not just the AI platform Professor Dash just shared, which is useful, but a key glue in exactly what you're talking about is the healthcare providers on the ground. And the challenge we see vary across what I've seen between high income countries and low and middle income countries. But interestingly, the common features are actually more than you would expect than actually the differences. So I'll give you an example. Something we saw in Australia is actually the challenges in primary prevention. Now, in Australia, we receive, so Australia has a universal healthcare system. You receive reimbursement as a general practitioner up to a consultation for 7 minutes, right? So you go in, you show them your Medicare card in Australia, any Australian citizen or permanent resident, and you get free care with no copay up to that 7 minutes, right? Now, the challenge is what can you do effectively in that 7 minutes, right? And because of sometimes these skewed incentives, that leads to significant gaps downstream in the potential care opportunities, right? Because that 7 minute consultation, I think your reimbursement is about $50 to $60. But the challenge is, and I might be wrong on that exact number, but it's in that range. The challenge is the value of potentially taking another 7 minutes to then comprehensively screen people, right, for conditions to better manage these chronic NCDs as opposed to just the acute problem is leading to these disparities, right? And so part of it's a incentives issue, part of it's a kind of policy issue. So where we're looking to kind of bridge these gaps, and now to sort of pivot that, what we've seen on the other hand, I think India is a wonderful example where we see some of the incredibly innovative work being done with what are called ASHA workers, who are basically community health workers who are trained, equipped with the right tools and technology. They've done an incredibly successful job being able to go and run these kinds of comprehensive screenings, and importantly to help task shift away from, necessarily say a doctor or even a nurse, which all of a sudden is a significant force multiplier in the potential we have for health access. So the way we've tried to approach this, and this is of course just one of several solutions, this is not the only means to tackle this, is through the structure of outcomes-based financing, where on the one hand you have an outcomes commissioner, that could be a government, it could be an insurance company, it could be a large employee health scheme. They're basically signing a contract with the project SPV to say, if you can deliver these savings in these defined areas, so it could be diabetes, heart failure, stroke, maternal and child health, over a 5-year horizon, we're willing to share a portion of these savings with you. If it doesn't work, we don't pay. And on that basis, investors then finance that project SPV, which then provides that funding to integrate that care to solve for exactly what you're talking about, Amelia, right? If it's a GP in Australia, to provide additional reimbursement to allow for that comprehensive screening. If it's a community health worker, to increase the number of them on the ground to have the capacity to do this and expand their reach and integrate with primary care as well. It would also fund Professor Dash's platform. And then finally, any smart health technologies like tablets, etc., you need to connect in. And what that's doing, what it kind of looks like on the ground. So this is an example of one partner we have called Parimal Swasthya. So they've worked with 112 million people to date in India. But this is kind of what it looks like on the ground, these community health workers, right? And so in this case, you're seeing mobile medical units. And this happens where there is no existing clinic. Of course, what you want to do is strengthen rather than replicate systems. So wherever possible, you actually do this worked in with existing government as well as private small-scale health facilities. So these are ways you extend the access. Now, within an Australian context, of course, you'd leverage existing GP clinics, but it may involve hiring 1 or 2 additional staff per clinic to be able to kind of do this. And this is how we're trying to solve for that continuity of care on the ground.
And just to give everyone here an idea of where this kind of innovative outcomes-oriented financing stands today, like how entrenched and common would you say that this kind of approach is today? And like, where is it even in terms of like investor awareness? Like, is it possible for an investor to like as a third party unrelated to like invest in the idea that this is like an effective and appropriate use of like social impact funding, for example, to move forward one of these solutions of a public-private outcomes-based financing partnership?
So I would say the biggest challenge right now is not the capital, it's actually the investable opportunities, right? From our engagement with, both asset owners, wealth management, insurance companies, pension funds, there's a growing appetite in it. The biggest bottleneck, honestly, is the investable opportunities, which is really what we've been trying to solve for in what we've seen. I think it's driven by a few things. One is the actual lead time in pulling a lot of these pieces together. But the other major challenge, a lot of interventions have actually been quite bespoke and relevant in one area, but then difficult to scale. The power of what we saw with Professor Dash's team out of Stanford, as well as the kind of cooperative governments between both the federal as well as state level in India and other countries in Asia, has been the real chance to kind of replicate that. Where if you think of that diagram I showed earlier, you can more or less scale the same solution, and all you do is you swap out the outcome payer, right? Whether it's one government for another, and then you swap out the local healthcare partner, but you've got that kind of overlay of the AI-driven insights driven by Professor Dash and his team at Stanford, able to kind of scale that. And that, I think, has been a key enabler in this. The successful social bank bonds we've seen is where they've been able to take these, and the UK has probably been the leader in this, where they've taken them and be able to replicate that in multiple areas within this. I think that's probably been, and it's no different if we think about the kind of, I go back to infrastructure is a really good analogy. The first infrastructure PPPs were very messy, bespoke, had a lot of transaction costs. Now, so many of those contracts are standard form, right? The entire procurement, contracting, EPC, and delivery process has been drastically shortened. So that, I think, is, and I think, if I think about where infrastructure's come, I think we're very much at the kind of, I guess, the start to midpoint of where I think the real potential is for outcomes-based financing within health.
Yeah, absolutely. I mean, it does. These seem like such win-wins. So it's powerful to see the examples of success and to see some of these sort of proof of concept examples of how they can be scaled. I guess one question I have is what are the channels and the mechanisms of change in making that happen? And maybe this is a good question for Varun, like in terms of taking what worked in one setting and really getting stakeholders in a different setting, maybe in a different country facing a different health challenge on board. Like what does that look like? Like who are the primary players advancing that, and what does it mean to try and get both governments and other parties on board with maybe trying something that perhaps feels experimental or new?
Well, I think, I do echo the need for having some sort of an innovative financing mechanism, which has, its roots in, more of outcome-based financing mechanism. I think it's a good, way to move towards inspiring or encouraging better quality of care. Saying that, I think, Amelia, I think one of the biggest challenge right now that I think every country, or rather most of the countries are facing, is actually the absence of a very robust data sharing monitoring backbone. Now, if you look at the outcomes-based financing mechanism, the fundamental principle is that if an intervention is able to drive or better a clinical outcome by a certain percentage, then there is some sort of a reward which happens, which basically to the intervention which has actually encouraged that better outcome. Now, the problem is that it is very difficult, first of all, to get what exactly is the baseline that we are looking at, and then constantly monitor the type of increase in the outcome, constantly track the progress of one particular factor and trace it back to the ability of that intervention to drive that particular progress. Because any particular progress in any particular clinical outcome is a culmination of many factors. And when you're trying to do that, how much will you accredit that particular increase that has happened to one particular health intervention or one particular health innovation? I think that is something which is very tricky for the government, because the government, from a government mindset or even from any particular financier, there is always going to be an organic growth, an organic increase and organic bettering of any particular outcome, because of course, the health services are getting strengthened, the infrastructure is getting strengthened. Now, the idea is that, with one intervention coming in, what is the type of effect that particular intervention is making? Now, the thing is that since this is very much closely linked with the commercial cost, this monitoring and this data, tracking is something which is very, very critical, because that actually will highlight how much commercials do you need to pay out to the particular health intervention provider. So I think that has been one very big challenge for the government. As Shan also mentioned that, the other place where we have experienced a similar sort of a challenge is actually the PPP frameworks. And one of the biggest challenge there is, making your contract agreements very robust. Whether it's with regard to the concessional agreement, whether it's with regard to, what exactly is going to be the scope of work. This is something which will take time. And I think there are a lot of pilots, POCs, which are happening across the world. Shan also showed a slide. But I think, we haven't really reached a calibrated state that, if we want to put this into an action, here is a toolkit and this is something that we can do. I think there is, more calibration which is required. But I definitely think that this is one approach that needs to be accelerated and needs to be, really put in action.
Yeah, thank you. Even just from a student perspective, causality is always the hardest thing in any, even just like an academic level. So I can't even imagine in a real world setting with real populations, really trying to measure success and how challenging that must be. I know that we're into officially the sort of the audience driven Q&A portion of the talk. So I want to make sure and be able to advance questions from those who have joined us. So I'll start by getting our most upvoted question so far, which is, could the panel please discuss vaccine distribution and how efforts can be more equitable both in the US and in the developing world?
So I was typing an answer actually, but I'll just say it. This is obviously my opinion, but I think it's not there's not a big difference between the problems that the US is seeing and the problems in other countries in the way that I don't think that we as a country had a good supply chain plan from the top down, all the way from the suppliers of the vaccine, all the way down to the clinics, the pharmacies, and other vaccination clinics or centers. Even in California, there was confusion. We had enough doses, but we didn't know where they were. These are crazy problems that we shouldn't be having. And I think you do need a system in place that is not fully reliant upon each individual government's local government, but has the full support of actually a federal government that can actually set a policy that is going to be distributed to all people. I think you need two things. You need enough vaccine, which of course we think we can overcome with all of the different options that we're generating. But you also need a really clear organizational plan to distribute that vaccine, and you need to staff it, right? We can't rely upon our frontline healthcare workers to also be giving all the vaccines to everybody. You need FEMA, and in some cases, you might even need the National Guard to be staffing and organizing these clinics, making sure this is a public health emergency, that we are actually dealing with that emergency and that type of urgency, right, from the organizational standpoint. And so we don't have that. We're hopefully moving closer to that. In other countries, I think it may not be as easy to solve with those kinds of resources, but I think that same kind of organization needs to be in place. And then other countries, they've done much better than we have, right? So there's examples of superior approaches and maybe ones that need more help.
Yeah, sorry, I just wanted to give everyone else a chance to chime in, but agreed. And also a piecemeal effort with different approaches certainly is not the most effective thing when it comes to a contagious virus that has no respect for state borders. So very much on the same page with you there. Another question that we have from one of our attendees is, as mentioned in the panel, the US has a very different healthcare delivery system than other countries. What beneficial practices and initiatives can currently be adopted so within our for-profit health system. So I know we talked a little bit on this during the panel about like things that are working in other contexts that may or may not work in a sort of fractured for-profit system that we have here. Are there any things that we can adopt that could have an impact more immediately?
Yeah, I'll sort of answer and you guys should chime in, but I think that it's a big challenge for not just the pandemic, but in general, prevention of chronic diseases. I think that the concept of paying for prevention is still an issue. Even value-based systems like I think Kaiser does a really good job on the prevention side, but even other value-based ACOs or accountable care organizations are not necessarily prioritizing preventive services. I think, for the non-value-based system, which is still about 80% or almost 80% of our healthcare system is still for-profit or pay-for-service or fee-for-service rather models. This is where negotiations with the pharma companies, the medical device companies, in terms of bringing costs down, needs to happen. Right now, our costs are for services and drugs is about 5 to 10 times what it is in the UK per unit. And occasionally a drug has been negotiated with the pharma companies to be similar, but we're always higher. And so by having that huge cost burden, it has created a lot of disparities in delivery of healthcare to our population. There's a lot of stratification based on socioeconomic status, insurance coverage, these kinds of things that leads to disparities in healthcare delivery. So it's not an easy solution, but I think that if you can rally around sort of government-based programs and initiatives that can do screening and do proper preventive treatments, at least a start, because these are not high cost interventions we're talking about. This is relatively low hanging fruit, and we can solve some of those issues at a population level with software and with that sort of integration of software into clinical care that's more intelligent and more targeted. It's kind of the approach we're taking with HealthPals internationally. We've done some work with value-based systems in the US that have shown merit, but adoption of that more broadly requires a sort of a governmental sort of initiative there.
I mean, with my sort of limited exposure in the US, Amelia, certainly what we've seen, some of our engagement, I think it's a much more focused approach. You're not able to necessarily cut as wide a cross-section. But, looking at certain components of insurers, right? So typically the kind of Medicare, Medicaid populations, other kind of at-risk groups, there may sometimes be economic incentives which still allow for similar type of value-based care improvements, but it's certainly a much more challenging approach than sometimes what we've seen internationally.
Absolutely. And I think in addition to the first thing I think of when you mentioned bringing some of those technologies into hospital settings is just that we also probably need some IT upgrades, maybe to make that happen. Another question that I think really taps into some of those points mentions the fact that Varun's point about the lack of an information sharing backbone and essentially asking whether we think that it's possible to achieve that kind of level of data sharing without having a single payer system.
I think in the last 6 months, what the country has started is a very interesting journey. We have announced a nationwide new health intervention, which is called the National Digital Health Mission. The purpose of this is to create information symmetry across different stakeholders, whether it is healthcare providers, whether it is policymakers, whether it is healthcare workers, and whether it's citizens. So the idea is that how do you take all the information, how do you digitize it, and how do you ensure that every single stakeholder gets this particular information in a digital manner? The idea is, and it's quite interesting, is that the government here is only taking the role of constructing the basic digital infrastructure. The idea is that, the government is playing the role that is, probably it is most suitable for. That is, I am a financier of the care and I'm a provider of the basic infrastructure. The top of it, things like making citizen apps, that is something that a private sector organization can probably do it in a much better manner. So the idea is that you open up this data information sharing for them, and on top of it, the private sector can make a lot of services which can actually benefit the citizen. And the principle behind this is having some sort of a very robust consent framework so that the citizen is finally the deciding authority of which data to share and which data not to share. So the idea is, taking into consent, taking into the principle of, privacy, and ensuring that there is information symmetry across different stakeholders. So of course, as I said that, monitoring and information sharing is really important. And I think this is one particular intervention that we think, would really help a country like India in the upcoming next, 4 to 5 years.
That concept is really powerful, of using government access and reach to like build the kind of database that then private sector players can then use to better allocate their own tools and inform their own strategies. Our next question is about virtual visits and telehealth. One of our attendees is wondering whether you all think that that shift is here to stay, or whether investment in those kinds of technologies will recede and become sort of a back burner standard of care after the pandemic.
So I can speak to some of that. So at Stanford, I started our first fully telemedicine specialty clinic about 3.5 years ago. This was before COVID, obviously, because our prevention results weren't as good as we wanted them to be, and they showed a dramatic improvement in engagement and even clinical results and outcomes with the telemedicine program that we put in place. And then during 1 week in March, during the lockdown, we went from 8 clinicians using that platform to 88 in the cardiovascular medicine division. And then shortly thereafter, the entire Stanford Healthcare adopted it. And we had solved some of those logistical issues of billing, which is, unfortunately top of mind for the hospital bean counters, but also for, just the quality and the technology that was being used. What we saw was obviously everyone moved 100% virtual initially. And then as they started to allow for in-person visits, that number has dropped. However, still about 40 to 45% of all visits right now at Stanford Healthcare are virtual. And it's actually likely that it will settle out in sort of the 30 to 40% range, we think. And it's because, as you said, in the question, that you can't examine patients remotely. There's definitely services that cannot be provided, and certain clinics lend themselves better to virtual care than others. And so, a heart failure clinic, you can't quite get a sense of whether the patient has too much fluid on board or not, or these kinds of things are harder to determine without being in the room with the patient. You can't listen to their lungs, these kinds of things. There are solutions to get around those things, right? In the UK, we know that there are booths you can go into, and you can wear a stethoscope in various locations and transmit those sounds. It'll take some time before that really becomes a full service type of solution, but the technologies are evolving rapidly. So I hope that there'll be a persistent adoption of this, because it beyond just COVID, it has the ability to scale the patient's time, and in many ways scale the clinic's time. We've done an operational efficiency analysis at Stanford that'll be published soon, showing that on average, our visits with a physician take up 22 minutes of a physician's time remotely if they're done virtually. The patient spends 22 minutes talking to the physician. If they come in person, they spend 86 minutes, and that doesn't include the commute time. So it's like checking in, waiting, getting your vitals checked by someone else, getting your meds verified, and then you have to see the physician, who's usually late, and so there's a lot of wasted time for things. So if you can see someone virtually, it's actually much more efficient and actually more effective, we found, in clinical outcomes. So, we hope the technology continues to evolve.
Yeah, I'm sure that there's also an impact just in terms of people actually going to checkups more frequently if it makes it easier. And there's a lot of health outcomes that come from that alone. Well, I know we're running close on time, so this may be our one of our last questions, but I think it's a good one. What innovations did you see happen during COVID that did not catch on, but wish that they did? And maybe I'll open that up to say, or even if they did catch on and it was something that you think is just really meaningful and maybe not discussed enough.
Yeah, I mean, I'll just weigh in quickly. I think telemedicine is one. So I think I'm disappointed that it's dropping into the 30s. I would hope to have stayed in the 50s or 60%. And I think we'll hope to see more of that. I think home-based testing and diagnostics is a big area that will continue to grow. I'm running a clinical trial at Stanford right now, which is the first fully decentralized medical intervention trial in cardiology. So basically, we're sending patients medications in a eventually a randomized study, and they get home EKG devices, they get home blood pressure devices, and we actually are now about to send them a home blood test kit where they'll draw their own blood in a vial, put it into a box, and send it off for analysis. This will unlock sort of the ability to recruit patients from anywhere and bring all these different patients into clinical trials who would never be able to do it because they don't live within a certain radius of a enrollment site, right? So we're able to recruit more broadly. These are the kinds of things that I hope to see persist and develop, and will be a big industry, I think, moving forward.
One of the key things I thought was quite interesting, to add to, I think, the important point Professor Dash made, is really innovative solutions around logistics. So one particular one we saw ramp up, one of the other companies we worked with is a group called Zipline, and they really ramped up. So they use drones to basically deliver essential medical supplies by parachute. I mean, these drones, I think they cover about 80 kilometers in 45 minutes. And they're now sort of being, tapped to see how they were already delivering vaccines and blood and anti-venom and things like that pre-COVID-19. They're now seeing how they can have a big role in solving some of the cold chain logistics challenges that we will face, especially in LMICs, in this rollout of it. And I think that's one that we're watching very closely, with the potential I think that really has to help solve for some of these issues of access and equity. Varun?
Yeah, I think, one specific theme of, innovative solutions that we saw getting a lot of traction, and unfortunately, I think, they are going to get more and more traction, are actually, not the telemedicine consultation side, but the telemedicine assistive solutions, which actually help the existing doctor workforce. So, to give you an example, something like a tele-ICU or a tele-radiology solution. In countries or like in country like India, wherein we still have, a low doctor to patient ratio, wherein the availability of doctors is low, and especially, the availability of specialists is low. Such type of solutions, they are really coming in very handy. Whether you have less radiologists, whether you have less anesthesiologists, those are the solutions which are actually helping, especially in the rural and the remote areas, because a lot of doctors, they do not want to travel in these rural areas, and it is very difficult for them to actually stay there and visit that place frequently. So we feel that these are some of the solutions that that emerged, or rather I would say that they were always there, but the type of adoption that happened during the COVID pandemic, I think that was very encouraging.
Well, thank you. I think that's a wonderful note to end on, just sort of touching on some of these inspiring things that continue to accelerate. I know we've touched on a lot today, but I think some common threads have been around the empowerment of new options for patients, whether it's home-based care or telehealth, and as well as the acceleration of some of these key solutions needed to drive forward the overall hopeful shift towards value-based care. So thank you to our wonderful panelists. A big round of virtual applause to all of you. Thank you for joining us today. It was really, really fascinating to get each of your insights. And I'll just remind any of my fellow Columbia MBA students that if you are in the audience and looking to get Philip's Pathway for Inclusive Leadership credit, please remember to click on the link in the box and register. And with that, I'll hand it back to our overall moderator. Thank you all for joining.
Thank you.
Thank you.
Thank you, Amelia.
Thank you, Amelia and panelists. We hope everyone enjoyed the discussions today and invite you to join us for additional panel discussions within the digital event series, which showcase the wide range of social impact capital and the possibilities across industry sectors to have social and environmental impact. At this time, we would like to invite our participants to please join us for a networking hour in AirMeet, a social networking platform. Once in AirMeet, you will have the opportunity to join conversations and meet fellow Capital for Good participants by moving between tables in the social lounge or trying your luck at speed networking. If you have any questions about AirMeet, please email the Tamer Center at socialenterprise@gsb.columbia.edu. Thank you and have a wonderful day.